around quality implementation of home visiting. By the end of that, we should be out of time, and we'll do a little bit of wrap up, just some reminder of how the action period will progress, and talk a little bit about the call for next month. Okay, so how about, without further ado, let's get into the review of our latest logistics. We've already talked about learning session number 3, and we'll get a review from you in just a minute. So let me talk now about the new core, what we previously referred to as satisfaction measure. Now I think we maybe need a more clever name for it, more generically for today at least. I'm going to call it the father engagement measure. And I'm going to switch documents here so that you can see the latest. Oh, that's not it. Okay, so I guess this is probably new for at least 2 programs, Frontline and CREOX, but for the rest of you, you'll recognize this first page. It's the same lead-in questions we had for Action Phase 1 under the Father Engagement Learning Collaborative. You'll notice at the top we have the same instructions. Our program is participating in a quality improvement project focused on father involvement. As part of this project, we are interested in learning more about father's engagement in home visiting and in child rearing. To learn more about this topic, we will be periodically asking you questions about a father figure in the life of your index child. For purposes of this project, we are broadly defining a father figure as the male identified as most involved in caregiving and committed to the well-being of the child, regardless of the living situation, marital status, or biological relation. A father figure may be a biological foster or adopted father, a stepfather or a grandfather, etc. He may or may not have legal custody and may or may not be living in the home. So it's a very broad question, very broad definition, and it may not be the same definition you're using for your individual PDSA, and if so, that would be perfectly fine. I see a comment to make this bigger, so I will do that. Thank you. But for the collective measure, and this is our collective indicator of progress among the entire group, this is the target population, if you will. So that's why the definition is broader. And you may want to make that distinction with mom during your visits as you're collecting this data. Before we get into the individual the individual items, I should say that we had quite a few conversations internally, also some conversations with each of the programs about how best to collect this information. We talked about it at the learning session. The idea was floated to use an electronic data capture system, perhaps one that was maintained by our evaluation team at the university. We've pulled away from that for a couple of reasons. One, I think it's going to be, it is certainly a little bit more of a burden on you all to collect the information, but I think our response rate is going to be much higher than if we had to rely solely on a separate system to be completed at the leisure of each of your clients. And that made me maybe the most nervous of all, knowing that this is the indicator we're going to send back to our grant funding agency as our measure of progress. So I would prefer that we continue forward with the same approach as last action phase, where the providers periodically will ask these questions of the clients. We are backing off of the monthly frequency that we used during the first action phase, and we're now requesting that you gather this from clients every other month. Just as we did in the first action phase, we will distribute reports. Now that those are built, those should start showing up a lot faster relative to the first action phase. So I think we can get some of these to you as early as next month. The plan is to meet with the health department later this week to talk through that process. We might be able to embed some of this within ETO itself and use the new alert system that Anira and John promoted at the learning session. It could be a combination of the alert system within ETO and emailed reports from us that look a lot like the reports received for the first action phase. One or both of those approaches will be used with the individual providers, and then our plan is to continue distributing the end of the month report to supervisors so that you can see what we see on our end when we pull the data out of the Learning Collaborative Touchpoint. Here are all the clients within your program where we received data. Here are all the clients where we didn't. And we'll also make a distinction between clients that we expected to get data from for that particular month versus those that do not, now that we're on an every other month schedule. Questions on that before we talk about the individual items? So every other month, each client. We will, in fact, in the email that goes out with today's monthly call link, the recording link, we will send you a PDF version of the instrument you see before you now. I know a lot of programs would take those PDFs, they print them off, take them to the visit, fill them out by hand, and then later enter them into ETO. So we'll make sure that you have this available to you. As I say this just now, it dawns on me that for the new items, we do not have a Spanish translation yet. So I'll reach out to some of the programs we connected with last action phase, see if maybe you can help us there. And then we do have some internal folks in our section at the university who can translate or help translate. So we'll be tabbing them as well.
David, this is Yolanda.
Yes. Hi, Yolanda.
So, hi, how are you? So it's going to be an ETO, another different touch point that was before, or is it the same? Sorry, I don't know if I missed that.
I didn't say it, but great question. I think the intent is for the old touch point to house these items, and we're just going to hide the ones that we're no longer using, the old satisfaction ones. But Anira, are you on, and do you care to comment on that?
Hello, can you hear me?
Yes.
Okay, awesome. So yes, we do have a PDSA touch point, and we can certainly make adjustment, like Dr. Bart said. And we're meeting later this week, and we'll decide what exact changes we're going to do. But if Dr. Bart plans to have a different touch point, me and John can certainly work on that as well. So yeah, we'll be happy to make adjustments as needed.
Dr. Bar, this is Patty. I just wanted to clarify that these new questions are going to be asked to everyone in our caseload, not just the ones that participate in the PDSA. Is that correct?
Correct. Yeah, and we will do a more careful accounting of which families would have actually been touched by PDSA and which ones would not when we report this back to our funding agency. But it is data that we want to collect for all clients who have an identified father figure. And for the time being, I'm skipping ahead a topic here, but for the time being, we're going to isolate this to only those where the index child is alive or has been born. So we do not currently have a version of this for mothers who are pregnant and the fetus is essentially the index child. Just to touch on the last topic briefly again, my preference would be we use the same touch point. So that one was named the Father Engagement Learning Collaborative touch point. And we'll hide the old items and then make visible the new items that you're about to see.
And I don't mind if you don't, I can translate it in Spanish if you don't have anybody, so.
Thank you. I will take you up on that offer, Yolanda. Appreciate that.
Yep, thank you.
I'll do,
I was thinking on those lines. Thank you for your input.
What I'll do is, just like last time, I'll probably take that translation and send it to a few others as well, including our own internal folks. and then we'll cross-reference everybody's thoughts and opinions on the best way to reword these questions for our Spanish-speaking clients. Okay, because we have some new programs, I'm going to quickly run through the lead-in questions. So the very first of which is, has the index child for this client been born yet? If they say yes, the index child is alive, you'll see that they'll be offered, or these additional questions we've created will be unhidden from that touch point, so you can fill them in. If they say no, mother is currently pregnant with the index child, then those questions will not be visible, and this touch point will essentially be wrapped up with one additional question. That being whether or not there is a father figure in the index child's life that fits the definition provided above. You'll say yes or no to that. If yes, is this father figure available to participate in home visits and other program-related activities? Yes and no. Many of you are tracking that for purposes of either your disruptor variable, some of you maybe even a process measure. If the father is not available for home visits, we ask why not. And this is the previous list that we had compiled. Work schedule will not allow it. Conflict between father figure and mother. Father refuses, declines, or is not interested, or other reason. And you can also specify that other reason. So those are the lead-in questions. We say 4 lead-in questions, but the 4th is really only if they tell us there's another reason why dad could not, or father figure could not participate in home visiting. Okay, everything you see highlighted is new. So notice that the numbers skip from question 4 to question 11, and that's because the old satisfaction items will be hidden. We had 3 satisfaction items for mothers where the index child was born, and 3 separate satisfaction items for mothers where the index child was not yet born. So those are hidden, and now we'll only have, for the moment, these next 7 questions. If they've answered yes, the index child is alive, we will have this short 1-sentence instruction for each of the following topics below. Please tell us how often the father figure engages with the child. Item 11 is, when he is available during free time, not at work, how often does the father figure spend time with the child? And I know we talked about this in the learning session. How should the response options be worded? We took, I think, what was consensus advice then, and also consensus advice among my own group, to focus on frequency. And so the responses here are related to frequency of occurrence. You'll see it begins with never, and then rarely, sometimes, often, and always. We have the same response scale for all 7 items. Item 12 is, when he is available, again, during free time, not at work, how often does the father figure change the child's diaper or help manage bathroom routines, toilet training, brushing teeth, bathing? Same response scale. Item 13, same lead in, and then how often does father figure help with feeding the child? Item 14, how often does father figure use your desired discipline practices, for example, placing child in timeout, to manage misbehavior of the child? Item 15, how often does father figure provide comfort, for example, hugging or calming, to the child when the child is upset, hurt, or sick? Item 16, how often does the father figure care for the child by himself without your help or supervision? And finally, item 17, how often does the father figure help the child learn new things? So again, same response scale. These will be numbered in order, and for many of the programs, you've adopted these items as your outcome measure for your specific PDSA. So we will not only be tracking the individual responses, but also the mean response across all 7 items, and looking to see if the mean response changes. For at least one program, I know this very first question is also of intrigue and will be isolated and reported individually. And then Andrew will be looking at these individual items at a very early stage in the process, just so that we can stay on top of how much variability are we seeing, and you know, how good are each of these individual items at capturing father engagement.
Dr. Barr, I have a question. With the one
Yes.
that is asking about how often that helps feeding the child, if the child is old enough to eat by himself, they might just say, well, he doesn't feed him because they already feed themselves. So can that be worded different? I don't know.
Yes. Oops. I'll make a note of it now.
Maybe it can be a not apply to that.
Yeah, that could be too.
Since it can apply to other kids, but not, you know, like
Or
babies
maybe-
and necessarily toddlers, something like that.
Or if he eats as a family, I don't know, something related to eating as a family, I don't know.
Yeah, I wouldn't say doesn't apply. I would say something like assists with feeding. I mean, he may not necessarily be feeding him, but like being present and available during the feeding to assist if needed or whatever, something like that.
If child needs assistance with feeding, those father, you know, helps, because he might not need help. Maybe.
Yeah, you know, I sort of see it the same way. Was that Connie that just said that earlier? I'm not sure whose comment that was. I'm sorry. When I'm presenting the screen, I can't see who it is.
I
But
think it was Dr. Bard, Connie.
It was
okay. Yeah, I think even if they're not, you know, spooning the food and sticking it in the child's mouth, if they're helping prepare the meal for the child, because you know, it's hard to imagine a 4-year-old or even a 5-year-old being able to do that for themselves frequently. I think that's still part of the intent of the item. So how could we reword this to capture that? How often does the father figure help with feeding the child? We could put, for instance, preparing the meals.
So could that be how often he takes part in feeding routine, maybe preparing or feeding or interacting with the child while it's
That's
food?
what I was going to say. Take part.
That's good.
Can you say that one more time?
So how often he takes part in the food time routine, like which could be feeding, preparing, or interacting with the child during meal times?
We'll work on this. I'm going to make a comment for it now.
Sure.
Okay, other comments on the core measure?
I don't know, maybe Dr. Barron, that 12, maybe it's because we're trying to promote also the reading. Can that be added, and toilet training, brushing teeth, bathing, reading, maybe just to have it there? Or do you think that that would not be part of the routines?
We talking about this one?
Uh-huh. Maybe just coma and reading or something like that, I don't know.
So we were focusing on bathroom routines only, based on some feedback we received from a couple of programs, and not bedtime routines necessarily.
Oh, okay.
You know, it is a good point that we don't, we're not addressing other types of daily routines besides feeding, I suppose. There are a couple of programs who are focused on reading and have their own individual question about that. I think for the sake of keeping it somewhat condensed, I mean, I recognize it's more than twice the size of what we had before, but the frequency has gone down. I'm going to try to fight my urge to add more items here, you know, even though I agree that's a good one.
That's using a lot of wisdom, David, I think. This is Connie again.
Thank you, Connie. I think I saw a comment come up. I'm sorry, I'm miserable at checking comments as I'm presenting at the same time, but let's see.
We can try to help you watch for comments, David.
Thank
I think
you.
I just worded my question there. That's it.
Thank you, Anira. I see it now. Okay, I'm going to copy that and move it over to my comment. Any other feedback on the common measure? Okay, as I said, you'll get a copy of this when the email for today's session goes out, today's call goes out. So if something occurs to you then, please email myself and include Helen on there. And we'll certainly take that into consideration before this goes live. Just so you're aware, we have a document put together. I'll circulate this also. It includes all the individual items from everyone's PDSA. So there's a comment at least about your outcome. There's a comment about your process and your disruptor measure. If those are unique in some way, then they're actually listed out. They're spelled out here. And this was also sent to the health department. So we'll be adding this content. My preference, at least, would be to add this content to the other existing touch point, which is named, I may need some help with this one, but I think it's fatherhood PDSA specific touch point, or fatherhood PDSA touch point, maybe. We will hide, if we're able to reuse that touch point, we'll hide the items that are not being used this round for your program. And you'll only see the ones that are mentioned here in this document. And you'll notice that every program has a heading here, so you can skip to your program and just make sure that this looks right based on the conversations we had in the follow-up call to learning sessions. Okay. Let me get back to the agenda real quick. So that covers these two bullets: external evaluation, data collection changes, program recruitment notifications. There's not a whole lot to update you on here that you don't already know. Our evaluation data collection has continued. There was a brief pause for a couple of weeks in March and most of April as we transitioned to a fully virtual version of our data collection. So we're capturing about 75% of the content we were previously capturing face-to-face, and that work continues. So don't be surprised, as always, if a client mentions that they've received contact from the university to participate in a study. That continues. I should mention, and this may not. You may not hear this directly from your clients. In fact, I hope you don't, but just so you're aware, we will soon start also interviewing or surveying clients of WIC programs who have not received home visiting before. And that was an element of this study that has been planned for some time now. We had to get all of our approvals in place, and then we had to overcome some COVID restriction obstacles, but we're through that now, and we anticipate interviewing our first WIC comparison families early August. So for those of you that operate out of a health department that may have a WIC office, I'm partly saying that for your sake. We have in the past had an instance where a WIC program did not realize this was happening, even though all the permissions were in place. So if that news ever does get back to you, if you'll let me know, I would like to reach out to those programs individually and just make sure we're all on the same page there. Changes to qualitative interviews. Not a lot has changed lately, but just so you know, there are a few more qualitative interviews related to the study that are being completed, but we are nearly done with those. Thank you for your help and assistance, especially those of you that actually provided or actually were part of one of those interviews. We greatly appreciate all of your input. Dashboards, we met this morning as an analyst team and talked about the creation of the template for this round of PDSA's template. I'm sorry, this round of PDSA's dashboard. So I would anticipate the first dashboards going out no earlier than the end of August, maybe more likely early September. We'll need to wait for some of this data to come in, the data that we just saw a moment ago. And but once it does, we'll be creating and adapting the tables and the figures that will go into those dashboards, and be sure to get them in your hands as soon as they're ready for prime time. Okay, I saw some comments come in. I'm trying to look at those now. Yes, there is some feedback, folks. So if you're not speaking to the group, if you would, please mute your line. They did ask my input, but I thought Omar was pretty. And I don't know, Caitlin, if you can hear that, maybe you can proactively mute some folks.
Yes, I'm gonna go through and mute everyone. Sorry.
And let's see, Susie mentioned, side note, WIC clients are enrolled in WIC Plus from Child Guidance. They don't want those clients enrolled in HV programs. Okay. I'm not sure I fully understand what that means, but I don't know that it was intended for me. Maybe I should ask Susie, what is WIC Plus?
Okay, I had to figure out how to unmute me. So whenever I was working in child guidance, WIC Plus is a program where the child development specialist will go meet with the clients that are in WIC and enroll them in WIC Plus, which means that when they come into WIC Plus, come in for the WIC appointment, they come in, they meet with them, and then they also get a book from Reach Out and Read. And they were collecting data on that, and they didn't want the data to be, I'm not sure I'm explaining this right because I never really quite understood, but they didn't want the data to be altered in any way. They wanted to make sure that what they were collecting on that client that was enrolled in WIC Plus was a direct result of being enrolled in WIC Plus rather than WIC Plus and then home visitation services, if that makes sense. But you talked about clients in WIC, that you were looking at clients being enrolled in home visitation services in WIC. So that's why I thought I'd mention that.
Okay. Yeah, no, I see why now. Thank you.
Was that relevant, or did I speak out of turn?
No, I think it is relevant. Yeah.
Susie, but how do we know if they're enrolled in WIC Plus? So that would be really difficult.
It will be difficult. So that's just something we're going to have to figure out.
Okay, forgive me, folks. It's storming here, and my machine where I'm sharing content is giving me fits, so I can't see the content. I stopped sharing my screen. I think I'm going to kick it to Helen here real quick, and the next agenda item is to do show and tell. Helen, do you mind running us through there? I had PAT Parent Promise listed first. And as I see the list, I'm reminded, you talked me wisely out of having everybody present this call so that we'd have time for the presentation. So we'll try to get through half of you today and then the other half at the next monthly call. But unfortunately, I'm not going to be able to share a smart aim or a change theory diagram if I need to, because my computer looks like it might be crashing on me now. You still have me, I'm on my phone, but when I'm back up and running, I'll let you know. and hopefully I get it working in time for the presentation.
Okay. Do you want me to pull up, or do you want the individual programs to pull up their documents?
If they have it ready, that would be great.
Okay. So the first one, as David just said, is Parent Promise.
Yes.
Hi, Shauna.
Hello. I do have mine.
Okay, if you want to pull that up, and like David talked about, we're basically aiming for about 10 minutes per program to just go through what your smarting is, what you're trying to achieve. Go through the change theory diagram if you have it available, and then talk about the outcome process and disruptor measures briefly.
Okay. Let me. Okay, can you see?
Yeah, if you want to just maybe open that up a little wider for people. Perfect.
Okay, so we're difficult and we're doing increasing the amount of virtual home visits. So our primary driver is the active involvement of families in home visiting using virtual platforms. I think we ended up setting our date for August 3rd. So that'll be our actual start date. Our SMART aim is to increase the number of home visits conducted on a virtual platform at least 10% by November. Our program, we have what we call baby bucks. We give our families baby bucks for completing visits and WIC appointments, well child checks, all that stuff, and they can shop in our store. And so we're going to increase the baby bucks for clients that actually will do a quote unquote face-to-face virtual visit instead of a telephone visit. Trying to think. We decided instead of, because we thought about just only giving baby bucks to parents that do virtual visits, but we really don't want to, what's the term I'm looking for? Like punish a family if they legit don't have a reason or don't have a way to do a virtual visit. So we're just increasing them if they will do. The disruptors are going to be no internet or data on their device, not having a device. And then we're going to try to track why it's not a virtual visit, and because we have a lot of parents that just feel it's uncomfortable and they just don't want to. So we're going to try to make sure we get that information. So we do believe that we can increase the percentage at least 10%. And that's about it. I do have my, this is our very simple change theory diagram. So increase virtual visits with enrolled clients, the disruptor being not having access to a smartphone, tablet, computer, or having data. Offering additional baby bucks for completing a home visit. And then we're hoping that this will encourage more client engagement and the parent educators to be able to get more PCI observations. And I think that's it. Did I miss anything?
No, I think that's good.
Yeah. Okay. David, are you able to see the screen?
Yes and no. my monitors are going on and off for some reason, and I can see it on my phone though if I need to, and I just squint.
All right. So can I stop sharing?
Yeah, let's move on to the next program.
Okay.
Thank you, Shauna.
Thank you.
Next program is Safe Care North Care. So one.
Hello, let me see if I can get this to share. My goodness. Can you see it?
Yep.
All right. So we have decided to adopt some of the National Safe Care's Dad 2K curriculum for our project. So the title is Dad 2K. And so our SMART aim, well, our overall primary driver is to increase involvement in the parenting. And then also we want to see the father figure confidence in his parent-child interaction through the safe care education throughout this module that we'll be doing. So our SMART aim is to increase fathers' knowledge and confidence in parent-child interaction skills by 25%. We will be doing this from July 2020 through November of this year by utilizing the Dad 2K curriculum and to track the percentage of fathers who report and demonstrate an increase of knowledge regarding their parenting skills. And we're going to do this by utilizing the Piccolo score. So we're going to do an additional Piccolo with our fathers before and after they receive this curriculum. And then there's another survey, the Parenting Young Children survey, that we'll also be completing with them. Our weekly outcome measures is to track if the father participated in the Dad 2K curriculum weekly, and did they demonstrate a gain of knowledge from the last week. We also, something that's just kind of built into our program is we have weekly assessments after we're educating the father or mother, so we'll be using those also to kind of monitor that. Then number of visits within a week where the father demonstrates gain in knowledge, and then number of visits within a week is how we're measuring that. The process measure is to track if the father participated in the Dad 2K curriculum weekly, and it kind of breaks down how we'll be tracking that is that the number of visits within a week or during the PCI module where the father participates compared to the number of visits a week during PCI. And then the disruptor measure, of course, is just a lack of fathers enrolled and that we can do this with, because we have a few fathers right now, but we may have already completed PCI, so we're really looking at new cases. The challenge is just getting new cases right now due to COVID, and then having fathers that will participate in this. And so, let me see. Can you see the change theory?
No, it didn't switch over.
Okay, let me stop and try again. Okay, can you see? All right. So our change theory diagram is that we had to get permission to have the Dad 2K curriculum. And then once we had it, we developed it to kind of work with what we have right now. And so what that is really, we're just taking videos from this previous curriculum and adding it to what we're currently doing with families. We had to take the time out to train the team since we are adding new information in just education materials to our program. So we took time to train the team. So of course the disruption is that if there's no dads in the program, and then we also have to ask dads to participate and then complete assessments. Another disruptor is if we have the dads, but they don't follow through with the curriculum and completing the assessments. And then of course dads will receive the Dad 2K education and increase involvement in parenting.
Great. Thank you, Dwan. Who comes next there, Helen?
Next is Creox.
Okay, Creox.
Okay, hi, that's me, Krista. I'm going to be presenting on ours today.
Hi, Krista.
Okay, let me just pull up ours. Sorry, one second. Okay, can everybody see that okay?
Yeah, looks like it's good.
Okay, so I'm sorry, let me make this bigger. All right. So our SMART aim is to increase male caregiver participation in at least one home visit by 10%, and that's a 35% total participation by the end of November. So, and then after providing the family with a welcome letter and a fact sheet about fatherhood engagement. So our start date is June 15th, and our end date is November 30th. Okay, our weekly outcome measure is looking at the count of fathers, attending at least one home visit. So right now we're just going to be focusing on home visits and collecting that data. And then the denominator is on the number of families with an identified father figure, such as father of the child, husband or partner, and other male caregiver. And we do want to collect data on that as we go along in the encounter forms. So process measures, looking at counts of clients that receive the letter or father-related materials, counts of each type of material reviewed or distributed, and counts of previous materials delivered to father. And our disruptors are father's ability or availability to join home visits, and then logging that as well in ETO. Okay, predictions. The father will be more engaged with their children if we include them in visits and group connections at a later time for the group connections. So we did come up with a welcome letter and a fact sheet, and we will be issuing that out to families very soon. Okay. And then I will go ahead and share our change theory diagram. Okay, so this is ours, and our process measures. The PE brings out the welcome letters or fact sheet to the home visits. Increased activities with child even outside of the visit, so looking at their interaction throughout the week as well, not just at home visits. And then that mom of baby shares materials with father figure, and ultimately leading to the increase in the father-child interaction. And our disruptors are that mom doesn't share info with the fathers, or that the father is unavailable to participate, or that the PE doesn't bring an activity out for a father figure. Okay, I think that's it for me.
Thanks, Krista. You know, while you were showing the template, I was reminded, I think we got this message to most of you, but not all of you. We have decided that the next learning session will be in January of 2021. So that gives everyone a little bit more time to work on this round of PDSA, this phase of PDSA. So it's not a big deal, but when you get a chance, you may want to revise the stop date for your PDSAs. If you stop essentially providing visits before the holidays begin in late December, you may want to mention, you know, December 15th or something like that, but you're welcome to continue it through the end of that month. And then we'll try to set the learning session for the first full week in January, where everyone's back and in the office.
Okay, thank you. I will update that.
Helen, I'm gonna let you keep going. I'm stable at the moment, but there's no
stable? Okay, the next one is OKC Public Schools.
So let me go ahead and try to share the screen.
All right.
And I think, okay. Can you see the screen or?
Yep, that looks good.
Okay. So we are trying to increase the number of visits completed. So we are going to try to, our SMART aim is try to come up with different strategies to get the parents for the completion of the visit. We were thinking for new families that we hope to recruit is to have like a welcome card, very simple, kind of like from the main office to say, hey, welcome to be to our program, to parents and teachers. And we also were trying to, after 12 visits consecutive, send like a thank you card and some incentives. It can be, we have books, or especially now that we are trying to do, that we have to do virtual visits, maybe some take to the family some materials like crayons, things that they can be continued doing the visits. We are trying to increase the percentage from the 50% to 85% by the end of the year. So we are trying to have two different outcome measures. Is the monthly visit completion rate, and also the percent of clients completing consecutive visits post July 1st. And of course, we are going to see that numerator is going to be a number of completed visits for a month, and the denominator, number of visits scheduled. For the outcome to number of participants, completing the visits consecutively, like 6 and 12 visits completed. The process measure is going to be tracking welcome and thank you card distribution. And that's something we need to get a ETO, a field in ETO. And I've seen, I can't remember her name for a minute. And Anita, is that your name? I'm sorry. She's going to try to get, yes, I am so sorry. It's keeping on my mind right now.
Perfectly fine, no worries.
To get that ETO field. We already had the number of cancellation is already a field that we already have in ETO. The disruptor is going to be cancellation of the visits. And of course, we have to add it, the new, I would say, disruptor is the COVID-19. The prediction is we're hoping that this improve the number of families enrolled in the program, of course, because we are trying to not to complete visits with the families they already have enrolled, but also enroll new families. And what we need to do is, of course, the educators, we're going to try to schedule more visits, more weekly visits. And of course, add the welcome to parents' teachers card and the thank you for your participation card. And like I was saying before, giving some kind of incentives to families. Who is going to put these is going to be, of course, the parent educators and the supervisor. And this is going to be all the families enrolled. So that's our plan. And of course, we were like families home, but for now we have to do this virtually. We are not allowed to do visits face-to-face just yet. So everything is going to be, for now, virtually. So I'm crossing my fingers on that. And I think that's pretty much it. I will go ahead and change, or let me see if I can move this in here. And this is the change of theory diagram. So that's what we have.
Thank you, Yolanda.
Great. The next group is Bethany Public Schools.
Okay, just a minute. I apologize. I'm in a different office. Our air conditioning stopped working. So Geneva has emailed me the documents. Thank you, Geneva. So let me see if I can pull those up. Geneva, my email is not opening. We're having storms here too. Can you share your screen?
I think I'm also having issues due to the storm. My computer just restarted.
If you want to send it
My
to me,
remote.
I can share my screen.
I might be able to pull it up as well. Geneva, is it on the server?
Yes, but I can also, for who was that, Caitlin?
Caitlin or
Sorry,
either one of us.
I was having issues connecting to the server too. I don't know if it's just,
It's a monsoon.
yeah, it's crazy. Well, my remote desktop is connected, but the one I'm connected to at home just restarted.
I think I have it here from the server. You want me to just share it?
Yes.
Sure.
Let's see. Does that look correct?
Don't see anything yet, Helen.
No? Oh, let's see, try now. How does that look?
Okay, yes, thank you so much. Okay, so for Bethany, our SMART aim is by December 31st, 2020. And so we might have to change that date a little bit as well. By asking mothers to provide evidence of an activity with the father and the child, 30% of the moms will report an increase in father engagement on the news survey. Our weekly outcome measure, we will monitor the mean father engagement survey responses. We had put monthly, but I think earlier you said that we would be doing that every other month, so we may need to make a change there as well. Our process measure is, did the client send a video, yes or no? And we'll also accept, we would like for the mothers to send videos, but we will also accept like a picture, or even if the mother can give us a summary of the father interacting with the child written, we will also accept that as well. Also, the number of activities that the father figure successfully completed with the child during the week. Our disruptor measure is, some different ones are the mother refused to provide father contact information to let them know the father is not involved with the child, father's work schedule conflicts, refusal to work with the child, relocation, illness, outside the home. Prediction is by encouraging the father to interact with the child one-on-one. We hope to see improved relationships between the father and child, leading to increased father engagement in the family. And our change theory diagram, do you have that as well?
Yep.
Okay. Yes, thank you. Perfect. To encourage the mom to get the dad to do an activity with the child, and we're allowing the mother to choose the activity, or the mother and father to choose the activity. And then the dad will select the activity to do with the child. The father and the child complete the activity together. the mom videotapes the interaction, and the video is sent to us, and hopefully father engagement is improved. Any questions?
Amy, you talked about looking into approvals that might have to be in place before videos can be exchanged. Any updates on that?
Yes, implied consent. If they send us a video, then we're going to take that as consent.
Okay, great. That's an interesting plan, and unlike any that we've used to date for this Learning Collaborative or the previous Family Engagement Learning Collaborative. So excited to see where that leads. Okay, I think we have one more, right?
Yeah, the last one was Frontline.
Frontline, okay. Hi, Deidre.
I'm here. I'm trying to. I don't know if I can pull up my screen. It's not letting me. I'm just going to tell y'all about our Smart Aim.
I can pull it up if you want.
Okay, that'd be awesome.
All right, let's see. Not sure which one's the most recent, so let me just check. Yep. Okay. So I will. Does that look right?
Yes.
Okay.
Okay, and I know that the date, our date is wrong because we're gonna extend it out. So we definitely will be changing that to December. But our Smart Aim is we will provide fact sheets to fathers and discuss routines within the first 2 visits, and then increase the average number of days a week the father leads and engage in a family routine by 10% in 5 months. Of course, that would change. We're going to change it to 6 months if it's going to be in December. And then for our weekly outcome, which we have kind of like a headline outcome, would be the average pre-post survey difference from the father's daily routine to see what the difference is with that. And then our process measures, we're going to use the number of fact sheets that will be delivered. And then some of the disruptors will be like if the father is no longer at the home, the father figure has been changed, and then the father figure refused to complete the survey. That is all on our question 3 in our father survey that we're going to be doing 3 times during this cycle. And then our predictions is Frontline will see an increase in the father's participation. And then the tools that we'll be using is baby bags. And then of course we'll have the surveys into ETO. And we have changed like our referral forms to also include the father's contact numbers, so that we can make sure that they will complete the surveys by, you know, if they don't show up via a home visit, then we can do fact sheets, texts, and then we can do calls as well to their cell phone numbers and not the mom. And then, do you have the
change?
Change, yeah.
That one that says
change.
template. Let me see if it's actually filled out for yours. Looks like maybe. Let me slide it over.
I think we've changed that some since then.
Does that look correct? It might be an older version.
It's an older version.
Okay. Yeah, it's the only one I have on file.
Okay. Well, that's all I can give, Dr. Bard.
That was great. Thank you, Deidre. And thanks everybody for that quick overview, and you'll get a chance periodically, for those that are new at least, to give us an update along with data as it comes in. We probably won't have a whole lot of data to share at the end of August, so we'll do this again for the other, I guess, roughly 6 programs, 5 programs maybe that we have left to have an active PDSA and didn't get a chance to review today. I'm still having some problems on my end, so just to be safe, either Caitlin or Helen, do you mind showing the slides that I sent you? And
I can pull them up.
I'll just verbally then give an indication of when I'm ready to move on to the next slide.
Sure.
As I mentioned in the agenda, I wanted to revisit this talk that I started back, I think it was in March, it might have even been February. And we were talking about implementation science and where this type of quality improvement work kind of fits into the bigger picture. I spent a lot of time talking about my personal interest, our team's interest in studying the impact of adverse childhood experiences on the development of a child. That, of course, was front and center in our last learning collaborative as we invited our colleagues from University of Kansas to join us, and you all were trained and then implemented aspects of the Lemonade for Life curriculum. And we were sort of educating our clients on the harmful effects of adversity on development, using that as additional motivation to engage longer with your programs. You know, that theme still exists, even though we've sort of changed the motivating topic of discussion to now how do we get fathers more engaged with these children. But the same end result applies. I mean, we're hoping that with higher quality involvement of a father figure, that children will build more resiliency to adversity, for instance, and be able to stay on track with their own development. Family well-being will increase, and of course, all of the other multitude of factors and outcomes that you track. We hope that sort of a rising tide lifts all boats here, and that's why we continue to monitor all of these outcomes through the evaluation project, in addition to what you're collecting for your individual PDSAs. So let me finish that discussion and talk a little bit more specifically about how quality improvement, particularly within the structure of the COIN framework, contributes to what I see as the bigger picture involving implementation science of early childhood prevention programs. So Helen, if you would, next slide. For sake of time, I'm going to skip through these objectives, and I may even be skipping some slides, so some of those I may not touch on, sorry. Primary prevention, evidence, and importance. Okay, so let me just set the stage for you and why this field of implementation science was really born. And for those who are not familiar with the term, it hasn't been around that long, so I wouldn't be too surprised by that, although it has gained quite a bit of popularity. And in fact, there are institutes now within our federal granting agencies that are focused directly on this topic, some of which, that's all they fund, are implementation science studies. Agencies like HRSA, which funds the MIECHV programs, they recognize the importance of implementation science and have essentially kind of baked it into all of their programming proposals. So Administration for Children and Families is very similar. Those two kind of work together on a lot of these projects. And it's not uncommon for their funding to come with the stipulation that you not only monitor outcomes, but you also monitor what they sometimes refer to as process measures or implementation measures. And the idea is that you're evaluating the quality of the program implementation and also the outcomes, knowing that these two go hand in hand. Next slide. Let's get through this. I think actually all the slides from before are probably embedded. Sorry. Keep going, keep going. Right there. Let's start there. So we're all familiar with the term evidence-based treatment or evidence-based practice at this point. And what that really indicates is that there's some literature out there that's based in scientific method indicating that a particular program or a particular model is effective. And of course, all three of the models that programs within this learning collaborative are practicing have such evidence and have received that label from one or two or more clearinghouses, if you will, that exist nationally and monitor these types of things as a large oversight group. But there is also this persistent and thorny issue of what many now refer to as the evidence practice gap. Next slide. Now this is for medicine, but this translates to behavioral health and to early childhood prevention programs just as easily, just as well. There is a consistent failure to translate the evidence from these original seminal scientific studies into routine practice. So from medicine, we know that about 30 to 50% of patients currently do not receive recommended care. So even though evidence does exist of what treatment is effective, it doesn't always mean that programs are going to implement it. And oftentimes they won't implement it at the same level of fidelity that the model developers might be advocating. 20 to 25% of patients receive unnecessary or even harmful care. 30% of medical spending is on unnecessary care. Like it or love it, hate it, wherever you stand, the Affordable Care Act was part of why it was able to get through Congress was that it was attempting to tackle some of these issues to make sure that programs and practices paid more attention to the outcomes that they were generating, and those who can eliminate this gap between what the evidence or the original studies showed the effectiveness to be and what they actually demonstrate the effectiveness to be in their practice, they would be rewarded for that in a way, or at least not penalized in terms of the amount of reimbursement they could receive for those services. So I think culturally, at least, the United States, in terms of its healthcare delivery system, is moving more in this direction of implementation science, and this is a topic that is more important than ever because of that. Many people have referred to this evidence practice gap as all breakthrough and no follow through. We have all of the scientific evidence, breakthrough knowledge on what would work, but then no follow through, meaning we don't take those practices and then carefully try to implement them out in the field so that this can scale and the populace can take advantage of it. It's estimated that the US wastes about $100 billion a year in what you might term as implementation or dissemination failures. The U.S. health system has moved to this value-based care, as I said, and recognizing that this evidence practice gap is wide and it's pervasive. Okay, next slide. More of the same here, and you've probably heard these statistics on any morning news program. You're bound to hear it touched on once or twice, especially in today's COVID pandemic days, pandemic times. We spend a lot of money on healthcare, and we don't get a whole lot of bang for that buck, at least not relative to our peers elsewhere in other countries. I don't want to spend a whole lot of time on that now. I think you know that. You could even highlight that within the U.S., we as a state tend not to gain a whole lot for our investments in healthcare. And, I would argue, many have argued that one of the main reasons for that is this evidence practice gap. Next slide. Okay, so as I said, this is not just a problem isolated to medicine. It's happening for all types of healthcare delivery systems. I would throw home visiting into that same bucket. Next slide. Home visiting is implemented with a process, and at any point in that process, if something goes wrong, you can expect that the outcome will not be optimal, right? We're going to lose some of the impact. So here is a diagram that was put together and published within the recently completed MIECHV study. You've heard me talk about that before. This is a MIECHV-funded large randomized trial. There were actually two versions of it. I think if we go to the next slide, we might demo that for you. These are some of the sites that were involved. The two different studies, there was the MIECHV study and then there was the MIECHV Strong Start study. They had slightly different but overlapping populations that they were targeting. Next slide. the left-hand column here, you see the criteria for the MIECHV study, the intention of it, and then also the targeted sample size right there in the middle. These, they did have pregnant women and families who were receiving NFP, but there were 4 other evidence-based home visiting models also included, and a large number of the families that were recruited had index children who were alive, but they had to be less than 6 months at the time of enrollment. On the right-hand side, you see the closely related MIECHV Strong Start study, which was only focused on women who were pregnant in less than 36 weeks gestation, 32 weeks gestation, sorry. About 3,000, just under 3,000 families in the Strong Start study, and about 2/3 of those were actually also participating in the MIECHV study. On the left-hand side, the MIECHV, you'll notice at the very bottom, over 4,000 families were involved in that large randomized trial nationally. I'm going to focus on the MIECHV study, although the results are very similar for the Strong Start study today. Next slide. And this is the only, I'm not going to go into the weeds here on the outcomes, but I would encourage any of you to look for the final report that HRSA did publish on these studies. You can see the effect sizes that they have listed there. I'm just going to give you a 10,000-foot overview. Each of these categories were captured for purposes of these 2 studies. You see kind of a broad summary for the MIECHV study in the middle, and then a broad summary for the Strong Start study in the far right. And notice that for the outcomes that are examined for each of these categories, rarely were those outcomes, well, maybe not rarely, but not frequently were those outcomes statistically significant. Okay, so prenatal, maternal, and infant health, for example, when we looked at just the prenatal women who enrolled in the MIECHV study, there was one outcome that they looked at. It was not a statistically significant difference between their comparison group. Comparison group were families who were not enrolled in home visiting. In the Strong Start study, they actually had 5 separate outcomes, and for none of those did they find a statistically significant difference. Let's skip down and look at parenting skills. In the MIECHV study, there were 2 outcomes that were examined. One of those was statistically significant, the other was not. Child maltreatment, 2 outcomes, only 1 significant. Child health, 4 outcomes, only 1 significant. Child development, 2 outcomes, only 1 significant. So, you know, in my opinion, the glass is half full here, okay? So we are finding significant differences. Generally, the effect, not even generally, across the board, the effect when statistically significant was small or moderate, which you might think is depressing. But again, glass half full. If you think about this program scaling out to all of those who need it, even a small effect is a big impact to the population, right? The other thing that I'll highlight that's not listed here that could get easily overlooked is that even when they did not have statistically significant effects, the vast majority of the time, the differences they observed between the groups favored the home visiting group. So the home visiting group was doing better than the comparison group, even when it was not statistically significant. So in the aggregate, we're talking about quite a few small effects, but those are additive. You know, they accumulate, and that means something. So if I'm making improvement in every one of these categories, even if it's only marginal, that combined effect, I think, others think, I'm sure you think, or I'll attempt to convince you at least, matters and is something that we ought to be pursuing, and one of the reasons why MIECHV continues to be funded nationally. Okay, that being said, there's clearly room for improvement here, right? Sample sizes, 4,000 in that middle column, more than 4,000, almost 3,000 in the far right-hand column. This is not a problem of not having enough people to tell if this is a significant effect. They had enough for these 2 studies. And again, when it was significant, it was still a really small effect. So you need big sample sizes to be able to detect the size of the impact for any of these individually. Next slide. So again, I'm thinking glass half full here. You might be thinking we're pushing the door in the wrong direction. It argues, in my opinion, for again, closer look at this evidence practice gap. What can we do to implement our programs with even greater quality than they're already being offered, which is relatively high? And what can we do to create even more separation between our treatment clients and our comparison cases, those in the community we have not been able to provide this service to? Next slide. Why does the gap exist? This is a long story. I'm not going to be able to touch on everything today, but I'm going to highlight some of the things that I think, one of the main reasons at least why this happens. Next. And as you'll see that, I'm going to use a clever trick. It's not really one reason. I'm going to give you about 10 all bunched into one. Definitions and concepts. For sake of time, I'm going to skip over a lot of this. Next slide, Helen. There are a lot of definitions out there. As I said, this is a new field. There is not consensus yet on exactly what this thing is, but there's a lot of commonality. Next slide. So for example, one of the things that's been fun for me as a behavioral scientist is to see, medicine adopt this approach as well and recognize that, it's not all about what the lab results are telling us. A lot of improvement in this area is about behavior, and they're looking to behavioral science now to determine how to better implement their programs, right? Because it depends on understanding behavior, understanding how a nurse and a physician interact with one another and how they both interact with their patient. Those things matter, and it always boils down to usually communication and behavior, things that normally would be in the social science realm. Developing strategies to change behavior. That's really how we're going to see improvement here, and how do we engage stakeholders in this conversation without, particularly for those who hold the purse strings, without alienating them, right? Showing them and having them understand this evidence practice gap, but explaining to them this is still a program worth funding, and let's put some funding into enhancing the quality of implementation. Next slide. Something that I will say that thankfully, agencies like HRSA and ACF and ARC, another agency that usually is on the medicine side of this discussion, they fully understand and they get, and the money is flowing to this particular problem. And here's a really subtle distinction, but one worth underscoring. So when we're talking about implementation science, right, that's different than the effectiveness of a program, or the efficacy of a program, I should say. So distinguishing implementation effectiveness from treatment effectiveness is critical for transporting interventions from the laboratory settings to the community health and the mental health venues. When such efforts fail, as they often do, it's important to know if a failure occurred because the intervention was ineffective in the new setting, or if the good intervention was deployed incorrectly, which would be an implementation failure. And so what we're focusing on now, failure is too harsh of a term. I think of this along a continuum, right? There are really bad ways to implement an effective intervention. There are extremely good ways to affect it, and there's everything in between, right? And so every program is somewhere along that continuum. And the work that you're doing now is all about moving up the ladder on that continuum for one particular aspect of your care delivery. Next slide. Okay, let's skip through this because we're running out of time. Keep going, please. And let's move on to, real quickly, I'm going to just touch on AIM. So these are some common outcomes that folks will pay attention to for implementation. Reach is what it sounds like. How far does your program go? And right, the farther it reaches, the more impact you'll have on your target population. Effectiveness is just of what you understand it to be. If you implement the intervention, what is the bang for the buck here? What do the outcomes change look like, or what can it look like? Adoption. So just because you have a service and it's available doesn't mean that it's going to be adopted by agencies that can deliver it. It also doesn't mean that it's going to be enrolled in, right, by your clients. We certainly understand that, and we've focused on that as part of our CQI efforts over the last several years. Implementation science, there are so many procedures involved. If I don't know how many were around long enough to be a part of the best practices work that we did, you'll remember, if you were around that long, that we started with a fairly detailed process map, and we had this circular diagram that we generated that started from referral paperwork showing up at the agency, and who grabs that and files it, and then what do they do with it, right? So every step along that process, from when the referral comes in to when we're conducting the visits to when graduation occurs, All of those steps matter in terms of enhancing the quality of our output. And a lot of that is maintenance, right? So once we have the client in the program, and once we have our staff fully trained and implementing with high quality, how do we maintain that over time? Next slide. One of the main reasons why the evidence practice gap exists is that because there are so many steps involved. Sorry, one more slide, I think. Is any failure along the way, or any misstep can lead to a weakening of the overall effectiveness. So even if an intervention is 100% effective, everybody that gets it is going to succeed. It's only so good as how and whether it's adopted. Practitioners are trained to deliver it. Trained practitioners consistently deliver it with fidelity. Eligible populations receive it, and it can be sustained. If you were to assume 50% success in all of those categories, now it's a simple math equation. And unfortunately, the result of that, 50% sounds pretty good. But if every one of those steps is only 50% successful, we're talking about a 3% benefit, right? So I think that this is why the evidence practice gap is so pervasive, that for every care delivery system, there are so many of these steps. And again, any misstep is going to water down the overall effect. Next slide. Okay, implementation science. Where does quality science fit in? There are overlapping circles in this Venn diagram. Next slide. There's some other topics. Dissemination science, you'll hear that talked about a lot. Comparative effectiveness, or RCTs. That's often the seminal work that's being done, and we decide this is an intervention. It does work. We need to scale it, get it out there. And then once we get it out there, our focus ought to be on implementation science, quality science being a big part of that. Next slide. And again, these are processes with lots of steps. This is a high-level view. So within each of these comments here, you could create a new process map, essentially. But this is home visiting. This is an implementation science paper from years ago. Needs to be updated, but you get a sense and a flavor for how many different balls are in the air at any given point in time, and you got to pay attention to all of those if you want to maximize benefit. Next slide. The MIECHV study. What was so unique about it, what is so wonderful about it, is that they were all the while looking at the outcomes and also had a host of implementation outcomes that they reviewed, collected, tracked, and then reported on. So there are actually two separate reports, final reports originally. They've been combined now into one giant report, the first half of which, or maybe even 2/3 of it, is dedicated to implementation science. These were some of the main findings from implementation science study. There was high staff turnover. Less than half of their providers were around for 3 years or more, or had 3 years or more experience in that nationwide sample of programs. Most trainings lacked role play skills, which we know is key to the uptake and the quality of fidelity implementation. Supervision hours were below model requirements in most of these sites. They paid really close attention to that. Support services like counseling, substance abuse services, these were not always easily accessible or effective. I know a lot of you are probably shaking your head right now, and you can relate to that. A lot of that depends on where you live, especially if you're in a rural community. It's hard to find those. High participant dropout. 17% of enrollees failed to receive one visit. I've preached over and over again that this is not an Oklahoma problem. I know we look at our retention numbers a lot and sometimes swallow hard. Everyone is experiencing this, not just us. A lot of people drop out, and when they do, it happens more frequently early on. Only 60% of initiators in this program completed half the expected year one visits. They tracked everybody for 2 years, by the way. Increased dropout among your high-risk families. We've seen that as well. 25 to 30% of visitors need more training on parent-child interaction facilitation and non-intrusive interaction strategies. I'm happy to report, you've heard us, rumors of this already, and you've heard it directly from me, I think, once or twice on previous monthly calls. We'll switch topics from father engagement to developmental monitoring and parental promotion of developmental behaviors next June. That'll be the topic of the next Learning Collaborative. So we already have the funding in place, and we're already working as a team here at the university, at least, on what the change ideas are going to look like for that particular topic. Low rates for addressing sensitive topics of substance use and IPV concerns. These were things they were hearing from providers of these programs around the nation. And because of that, it showed up in the data. The clients also reported this, that rarely was this a topic of conversation in a visit, or at least they didn't remember it that way. And then finally, difficulty engaging mothers who were dealing with trauma and frequent crises. That one, of course, we attempted to address pretty emphatically with our last family engagement learning collaborative and the use of Lemonade for Life. Certainly more we can be doing with that in the future. Next slide. I know I'm out of time, I'm sorry, but you know, one of the other reasons I think that this problem exists, the evidence to practice gap, is that usually the initial evidence comes in, and then there is this unwieldy and unwelcomed lengthy process from when the evidence first arrives to when it gets publicized and vetted by the scientific community, and then agencies gradually start to adopt it, and then eventually, often 17 years later, we find, on average, this thing is actually available to a sizable chunk of the population. That's too long of a gap. I mean, by the time 17 years have passed, what may have been effective nearly 2 decades ago is likely not going to work, not to the same extent. So this is a major problem, and one that the field has been reticent to address. It's just sort of front page headlines these days with COVID. We're dealing with the same problems with these drug trials. Not to say that we shouldn't be very patient and very careful about how we vet these interventions. We should be, but clearly there's a problem with the majority of this type of science that we do, of finding the evidence and then disseminating it and getting it implemented widely. One of the reasons I was attracted to the COIN framework for the use of CQI is because it does circumvent this issue. There's a wonderful, it's not showing up here. Oh, maybe there's another slide. Sorry, one more slide. Yeah, there's a wonderful video recording of Dr. Mary Catherine Arbor, who was one of our guest speakers at a previous monthly call for our family engagement collaborative. And the link is up above. We'll send you these slides, but I would encourage you to go watch that. And she makes that same point, that, you know, this is an approach. What you're doing now is an approach to try and get evidence into the hands of practitioners more immediately, right? So by all of you working on this collectively, learning from one another, we're hoping to speed up this process and narrow that gap even faster than we normally would. So 10,000 foot overview here, but I think it bears probably repeating, not only today, but as we move forward, that, you know, the work you're doing is so important. And the lessons that you learn are not only being shared and benefiting programs here locally, but we're taking this and publicizing it elsewhere, and other programs are also being able to take advantage of what you've learned and implement it on their sites. So that's where it fits in the bigger picture. You're a part of this. I just wanted you to know that. And if ever any questions arise about what's happening with our data or maybe other data like it, please let us know, and we'll make that another feature of one of these upcoming monthly calls. Sorry to go over a little bit. Questions or comments before we wrap up?
David, I just sent a message to everyone. I've got a lot of things in my head about what you just discussed, and I would like to just email you some questions in regards to this information that you just shared. Is that okay?
Oh, absolutely. Yeah, thank you, Connie. You know, normally we run through the list of things to pay attention to. There's not a whole lot new on that list, but you know, please be on the lookout for emails, particularly from Caitlin, as we try to schedule the next monthly call. We'll shoot for the last week of August for that. You'll get the link to today's recording, and as I said, we'll also attach a PDF with the new core measure. That may be a day or two later than normal, because I'm going to go back to that item we discussed today and reword it so that the feeding item fits all families a little bit better. So
Dr. Bart, you're going to let us know when the new measures are already in ETO, because I know that on Friday we mail 5 of those welcoming letters. So just to start documenting that in ETO as soon as we can.
Yes. Yeah, I'll contact Anira and John. We'll try and be in concert as we deliver the message that those are live. We're meeting on Friday. My hope was that we focus on the reporting side of that, but there may be some issues that we need to resolve about how we embed this within the touch points too. So if so, Anira and John, if you're still on, I see Anira, just let me know, will you? And I'd like to get that in the hands of the providers as soon as possible, and then make the focus of Friday's conversation more on how we're going to report the data that has come in back to each agency.
And I was going to ask you if you want to send me those the questions. I think I took a few pictures, but I know that we were doing some changes. If you send me the questions, I will start translated into Spanish.
Thank you, Yolanda. I will do that. Okay. Thank you all for joining. We'll be in touch soon. Some of you are selected for a quick review of your next PDSA, just like you saw the 6 programs do today. So if you weren't on the list today, just know we're going to call your name next time, so you may want to just prepare a little bit in advance. I'm happy to set up a call if you want to talk that through, but it won't be a whole lot different than what we talked about during this month's call. And then shortly after that, we'll set up our routine rounding calls, and we'll start preparing for our show and tell as data comes in. Okay, thanks for bearing with my technical glitches today. Thank you, Helen, especially. And we'll catch everyone very soon. Have a great afternoon.
Thank you, Dr.
Thank you. Thank you.
Thank you all.
Thank you.